So welcome everybody. My name is Kelly Buckroyce and I work with the Alberta SPOR Support Unit Capacity Development Platform. Before we get started, I'd like to acknowledge that although we are meeting virtually, each of us live on the traditional lands of First Nations, Métis and Inuit people, whose histories, languages and cultures continue to influence and enrich our vibrant community. So I'm very pleased to welcome you today to part 2 of our Studentship Awardees poster presentations. Before we get started, just a few words of housekeeping. This session is best viewed in speaker view, not gallery view. Please keep your video camera off to ensure your privacy and to prevent interference with your audio through the session. To access reaction buttons such as the thumbs up, click on the participants at the bottom of the live stream window. You'll then see the reaction icons at the bottom of the participants tab. If you have any questions, please post those in the Zoom chat box or in the Whova Q&A box or the Whova chat box. And we do have Christine Salinger here from our team to help with moderating questions. So we have five presentations today by our Studentship Awardees, whose research is supported by the Alberta SPOR Support Unit. Each student will have 5 minutes to present on their research, followed by 5 minutes for questions following their presentation. So I'd like to, at this time, introduce our first speaker, Christy Chong, who is doing a master's degree in health services research at the University of Calgary. And Christy's poster presentation today is titled Determining the Association Between Continuity of Primary Care and Acute Care Among, Determining the Association Between Continuity of Primary Care and Acute Care Use Among Adult Patients with Chronic Kidney Disease in Alberta. Thanks very much, Christy, and I'll turn it over to you. Take it away.
Thank you so much, Kelly, for the introduction. So thank you again for everyone for attending this poster presentation session. I'm very excited to present my work today. So my name's Christy Chong and I'm a second-year master's student at the University of Calgary in the Department of Community Health Sciences, and I am specializing in health services research. Under the supervision of Dr. Paul Ronxley and Dr. Megan Elliott, we have been working on my master's thesis project, which is to determine the association between the continuity of primary care and acute care use among adults with chronic kidney disease in Alberta. So chronic kidney disease, or CKD, is the gradual loss of kidney function, where your kidney function is below 60% of normal healthy kidneys. CKD affects approximately 12% of Canadian adults and is often accompanied by multiple comorbidities such as diabetes and hypertension. Given the complexity of care for this disease, individuals with CKD often use a lot of acute care services such as the emergency department and the hospital. While individuals with advanced CKD are usually cared by their kidney doctor, 9 out of 10 patients with CKD are usually cared by their primary care provider. The continuous beneficial relationship between a patient and their primary care provider is called continuity of primary care. Continuity of primary care can be used to measure the quality of care that is being provided by a family doctor over time. And among general populations, having strong continuity of primary care is associated with greater patient satisfaction, increased quality of life, overall health, and reduced rates of acute care use. However, we don't know if improving continuity of primary care will influence the downstream use of the emergency department or hospital among individuals with chronic kidney disease. So this brings me to the aim of my project, which is to determine if there is an association between continuity of primary care and rates of acute care use among patients with chronic kidney disease. This will be a retrospective cohort study from 2011 to 2014, and the cohort will consist of adults who reside in Alberta and have a kidney function less than 60% but are not on dialysis. They must also have at least 3 visits to a single primary care provider in a 2-year period before their CKD diagnosis date. The exposure variable is the level of continuity of primary care, and there will be 3 levels: poor, moderate, and high continuity, and this will be determined using the usual provider continuity index. The outcome variable will be acute care use, and we are particularly interested in the rate of emergency department visits and the rate of hospitalizations. Descriptive statistics will be used to summarize patient characteristics and comorbidities, and this will be stratified by the level of continuity and by CKD stage. And then statistical modeling will be used, and we will adjust for patient clinical and demographic characteristics. This project champions 2 patient priorities that were published in a 5-year transformational roadmap by the Kidney Health section of the Medicine Strategic Clinical Network. Specifically, our project targets the priority to improve the management, coordination of care, and outcomes of patients with CKD. And the second priority that this project aligns with is to reduce avoidable emergency department use and hospitalizations. Through the support of the Strategic Clinical Network, we will be engaging with patient partners as they will help us review the findings and guide the dissemination of the results to key stakeholders. And these stakeholders will include other patients with chronic kidney disease, decision makers, kidney healthcare providers, and kidney researchers. So as a result of all of these collaborations, this project will be the first step towards informing future interventions to improve the coordination of care and reduce the burden of avoidable acute care use among patients with chronic kidney disease. I would like to acknowledge and thank the Alberta SPOR unit for supporting and funding my project over the past year. Thank you to all of the SPOR experts who have helped guide this research, to my committee members, Dr. Paul Ronxley, Dr. Megan Elliott, Dr. Dave Campbell, and Dr. Fariba Agajafari. And thank you to James Wick for helping me create my cohort. And thank you to everyone in the audience who is listening, and I would be happy to take any questions.
That's great. Thanks so much, Christy, for that. I'll just throw it over to Christine, who's in Huva, and ask if there's any questions in Huva for Christy.
Sorry, guys. No, there isn't any questions.
Okay, great. If you do have any questions, feel free to post them in the Zoom chat or the Huva chat or Huva Q&A box. And I actually do have a question for you, Christy. I'm wondering, how are you working around COVID-19 to have the best project possible?
That's a great question. So because this is a retrospective cohort study, most of this data is available through the Alberta Kidney Disease Network, which is an established computerized repository of lab data from across Alberta. And so this gives our team an advantage, particularly during the COVID pandemic, as all of this data is already collected. One area that has been impacted is our ability to engage with patient partners in person. However, my co-supervisor, Dr. Megan Elliott, she has made fantastic connections with all of the patient partners, and I will be utilizing these connections to engage with them using electronic platforms.
Great, thanks very much for that answer. And as a follow-up question, where did your research question come from, and what do you plan to do with the results?
So the research question came from the 5-year transformational roadmap that was published by the Kidney Health section of the Medicine Strategic Clinical Network. And so the Kidney Health section of the Medicine Strategic Clinical Network is a multi-stakeholder organization that meaningfully incorporates the patient perspective in all of their activities. And so they worked on this transformational roadmap that outlined the goals that they wanted to achieve over the next 5 years for the kidney community. And it also includes the priorities that are important to patients. And so when I was reading through that, we identified 2 priorities that we wanted our project to align with, and that's how we developed the research question for this project.
Fantastic, thanks very much. And I do have a question in the Zoom chat for you. Excellent presentation. Can you explain the continuity of care index that you're using? And does this account for or define for the member of the primary care team? For example, does it identify or give a higher score to patients who saw only a physician versus seeing a dietitian and nurse as well?
Mm-hmm. So thank you so much. The continuity of primary care variable that we're interested in is basically a proportion of outpatient primary care encounters that were made to a single provider during a 2-year period before diagnosis date. And in terms of the people that they see for this project, we defined primary care provider as only family doctors. And so there will be 3 levels of continuity of primary care: low, medium, and high. And that is all based on how many, or the proportion of visits that they made to a single provider. So if they saw one primary care provider a lot, then they might be put into having higher continuity of primary care. And the equation that's used for that has specific numbers that determine which level you can have for continuity of primary care.
Great, thanks very much. And one final question before we move on to the next presenter. What aspects of care do you think from your work so far will be critical to the continuity of care?
What aspects? So I think the findings from this project are really the first step to figure out if having a strong or poor continuity of primary care influences the rate of emergency department visits and hospitalizations. And if we do find an association, then that allows us to figure out what are the characteristics of those who have higher rates of emergency department visits and hospitalizations. And once we figure out those characteristics of those patients, then we can develop specific interventions to try to enhance or understand why they might be having low continuity of primary care.
Oh, and I see, I think we have time. Just one last question here. Following up on physicians only, allied health team models seem particularly appropriate to your study. More of a comment than a question.
Mm-hmm.
Yeah.
Yeah, so sorry, I'm just gonna read the chat. Allied health team models seem particularly important. Yeah, I think so. Yeah, for this study, we will only be focusing on the relationship that a patient has with their primary care doctor. But I think it would also be very interesting to explore the relationship that they have with other individuals in their that are involved in the care of their illness. So that could be a future project or extension to this project in the future.
Great, that's a great insight, Christy. Well, thank you very much for a wonderful presentation. Well done. And thank you to everyone who asked questions. So I will now introduce our next speaker, Billy Wang, who's doing a Master's of Science degree in Medicine at the University of Alberta. And Billy's presentation today is titled Implementation and Evaluation of Novel Supportive Care Initiative in a Multidisciplinary Heart Failure Clinic. So welcome, Billy, and I'll turn it over to you. Take it away.
Thank you so much, Kelly, and good afternoon, everyone. And thank you so much for this wonderful opportunity to present the work that I've been doing at the Heart Function Clinic at the Massachusetts Heart Institute. So what we know is that heart failure is associated with a significant symptom burden, and that results in an overall impairment in patients' quality of life. And since there's currently no cure for heart failure, we describe this as deteriorating in waves. So patients would recover initially following medical therapy as well as device therapy, but then they decompensate again. And that comes in waves, which is very, very stressful for both patients themselves, as well as the heart failure caregivers. And in 2017, the Palliative trial, what they did was that they randomized 150 patients to either receiving just conventional heart failure care or integrated palliative care on top of that conventional care. And they found a significant improvement in symptoms of depression, anxiety, as well as the Kansas City Cardiomyopathy Questionnaire, KCCQ-12 scores. I'll come back to this in just a second. So currently, referral to palliative care is recommended across international guidelines, and that includes the 2017 Canadian Cardiovascular Society heart failure guidelines as well. And the term supportive care is used preferentially, and this has been shown with real-world evidence that it helps mitigate the often negative impressions patients have on the term palliative. And again, I think that just goes into kind of eliminating and bringing down that barrier for patients to access these important initiatives. But what's challenging clinically is how can we identify patients early on, those who may benefit from supportive care, so that they could receive the maximum amount of improvement in quality of life. Because we really don't want to just have supportive care started in the final few months of life when the benefit is very limited. So that's why I think there is an incredible opportunity here to involve patients as research partners on this project. And in terms of POR methodologies, our choice of patient-reported outcome measures, the PROM tool that we use, is informed by the pilot work we've done with the patient reports. Because when patients are coming to the clinic, they're usually there for hours at a time, and that could be very tiring, especially for patients with heart failure. So we wanted to find a tool that could both be very easy to do and understand for patients, but is also meaningful to guide supportive care referrals. And the one we chose was KCCQ, which is a disease-specific measure for heart failure, and it captures things like physical limitations, symptom frequency, severity, patient self-efficacy, as well as social limitations. And what's interesting is that the development of the KCCQ itself also involved many of the methodologies we learned through the online Alberta SPOR patient-oriented research training modules, in that they also conducted systematic reviews, they evaluated existing PROMs, and they consulted both patient and healthcare focus groups. And another interesting thing to note here is that we actually had to use a condensed version of KCCQ down to just one page, because we found even with the original KCCQ, which was several pages, patients were still having trouble completing it. So we chose to use the shortened but also still validated KCCQ 12 instead. Another potential benefit from the study is that by doing in-person interviews and gathering patients' experiences, it not only increased patients' empowerment and involvement, but also in this process, patients can also reflect upon their personal values and idealization of the supportive care referral process. This way, later on down the road, let's say the disease progress and the clinic staff has to approach them about these difficult conversations, hopefully it could make a smoother transition for the patients. And in terms of methodology, when patients are seen at the outpatient clinics, they first consent to our heart function clinic registry. Then we do patient experience interviews as well as quality of life assessment, and they fill out the KCCQ questionnaire as well. Additionally, we also have access to Alberta NetCare as well as eClinician, and more recently Connect Care. And this way we could have just a comprehensive understanding of the burden of heart failure that's present in our patient cohorts. And in terms of the supportive care pathway, currently at the heart function clinic, usually the cardiologist and a lot of cases nurses themselves, they would be the ones starting the heart failure referral. Then patients are referred to community supportive care specialists where they have consultations, need assessment, as well as follow-ups. And oftentimes the supportive care physicians, they actually come to the clinic themselves, and they could also go out to patients' homes as well to do these assessments. Again, just our colleagues just really wanted to maximize and make themselves really accessible to the patients. And as a patient, they have access to many levels of support through this process, not only from our clinic, but also from primary care physicians, the emergency services, emergency department, home care, as well as their family and support groups. And in terms of some of the preliminary results we have already published as part of our study, what we found was that the different domains, for example, jogging, walking, showering, these are reflected. So these are on the KCCQ. And for example, these domains, they reflect physical limitations. Shortness of breath, fatigue are like symptom frequencies, as well as social limitations and quality of life impairments. And these are very affected to various degrees in our patients. And using a KCCQ score of less than 29 as a cutoff, and this cutoff has been established by a multi-center study in the UK, and they found the score of less than 29 was a very strong predictor of need for supportive care. We found that out of a cohort of 456 patients, 9% of these patients could potentially benefit from supportive care referral. And if you extend that to the broad general clinic, so we follow roughly 1,300 patients across northern and western Canada, that's almost 130 patients that could potentially benefit from this initiative just in our clinic alone. And patients with a score less than 29, they do very poorly in their domain score, characterized just by an overall poor quality of life. And panel D and E is just showing some of the outcomes that we already have for patients who has been referred to the supportive care service so far. And what's important to note here is that we are seeing a shift away from patients dying in emergency departments and hospitals towards dying more peacefully back at home, and also palliative care units. However, as was shown in the PAL-HF trial I just mentioned, there was no significant improvement for survival of patients. So it's more related to their quality of life and kind of just having a more peaceful death. Oops. Sorry, I just accidentally clicked somewhere. 1 second. Okay, so lastly, to talk about the expected outcomes and future direction of our study, what we are hoping to do with this initiative is to be able to optimize the screening and timing of referrals to supportive care using validated prompt tools, as well as identifying barriers to access of these initiatives. So ultimately, what we hope to do is be able to compile a checklist of the patient-identified conditions, as well as clinical presentations that likely warrant supportive care referrals. And here you can see why it's so important for us in the study to incorporate the key stakeholders, including both patients, as well as the multidisciplinary heart function clinic staff. And this checklist will also help us guide screening and identification of patients from the registry to allow more timely assessment of supportive care initiatives. Additionally, we're also partnering with the SPOR data platform to optimize our research methodologies and also to access linked admin healthcare databases. And this way, we could evaluate the performance of referral strategy with clinically relevant outcomes. Our clinic is also actively participating in the integrated supportive care pathway through the One Path province-wide program, which Dr. Sarah Davidson just had an exciting talk about it earlier today. So on top of heart failure, patients with advanced kidney, liver, lung diseases, as well as cancer, with this program, hopefully they're able to be better supported out in the community and not just in the specialist care setting. So one phrase that I heard from the supportive care physician in the clinic is longer life without a higher quality of life is just prolonged suffering. And I think that really resonated with me. And I think that highlights just how important our research is while also why, we see clinics around the world adopting supportive care initiatives. And we hope that by sharing our experience with the incorporation of the initiative, we're also able to help inform future guidelines for heart failure care. Lastly, I just want to end off by sharing a patient experience from the clinic. So this patient had a traumatic experience of watching his wife pass away in the clinic due to advanced heart failure. And in the hospital, they were giving her, ventricular assist devices while also on the cardiac transplant list. So after seeing that experience, he really wanted as much management from home as possible. And I think that speaks to the importance of, in the clinic, we need to be able to kind of match the patients where they're at. And also just really use patients' self-opinions to guide the referrals to supportive care initiatives. And finally, I just want to thank the incredible support from the SPOR Graduate Studentship in Patient-Oriented Research, as well as the University Hospital Foundation for making this work possible. And also thank you guys for giving me this opportunity to present the work. Thank you.
Wonderful. Thanks so much, Billy. What a great presentation. I'll just throw it over to Christy now to ask if there's any questions.
Yes, we had one question in the chat, and everyone can feel free to continue to ask questions. But this question is, supportive care is not just palliative, but appropriate to most chronic conditions because it improves patient control of their final stages. Have you looked at the St. Christopher's hospice models of care that are very patient and family driven?
Personally, for this project itself, we haven't done that yet, but I will make sure to take a look at it afterwards to see how we could better incorporate that into our study.
Perfect. Thanks very much, Billy. And one last question before we move on to the next presenter. What feedback have you maybe received from clinicians on how this initiative has impacted any practice change for them? And is that part of your plans for this project?
Yeah, so getting feedback from the clinicians themselves is very important. So far, the referral to the supportive care initiative is mostly based on perceived needs by the clinicians as well as the nurses at the clinic. So I'm planning to present this study also to the heart function rounds as well, so we could get some feedback from the clinicians themselves. But the ultimate goal, of course, is to develop that framework of a checklist of questions that the clinicians themselves could use to help, guide the supportive care referral process.
That's a great answer. Thanks so much, Billy, and a wonderful presentation. So I will call on Matheus next, who is the next presenter. Matheus Mussi is a master's student in rehabilitation science at the University of Alberta, and he's presenting today on user-centered design of brain-computer interface systems for children with disabilities. Take it away.
Hello, everyone. Can you see my screen all right?
Yep, it looks great.
Okay, cool. So my name is Matheus Mussi, as they said. I'm a master's student in rehabilitation science. My background is in engineering, and that's why we're going to see the research is not just healthcare oriented. It has a bit of more of a engineering kind of feel to it. And I'm currently working at the AT lab, supervised by Dr. Kim Adams at the University of Alberta. And I'm finishing my first year master's right now. And my research deals with brain-computer interfaces. So what are brain-computer interfaces and why are they needed? So we have children with disabilities. They usually rely on assistive technology to be incorporated in society. But most of those assistive technologies are not exactly accessible for them, some of them, depending on the disabilities they have. So what BCI does is a device that uses, instead of physical, like hands, arms, it uses the brain, like the signals from the brain. And that allows kids to be inserted in society using that assistive technology. So we can do that because most of the disabilities they don't compromise cognition, and that allows us to use that kind of technology even for patients with disabilities. So our project is going to be basically separated into 2 stages. One of the stages, we're going to be developing the system. So we're going to try combining 2 different kinds of brain signals, because brain signals, depending on how you excite the brain, it gives you a different response. And we know that single input brain-computer interfaces are not having the performance patients expected. So what we want to do is include more signals, and in our case, it's going to be 2 signals, so we can have a better performance, less fatigue, and more independence in the process. So the first stage of the study, we're going to test those systems with adults that don't have disability, but also with adults that have disability. And that is just for the sake of having a better feedback and knowing what exactly to tweak and how to increase the performance of our system in a way that the participants like it. And then we're going to use what we call a user-centered design, where we iteratively ask them how the prototype is, how can we improve it, and then we improve it over again. And then in the second stage, we're going to actually use that system with children with disabilities. So in the second stage, we're going to be going to the Glenrose Rehabilitation Hospital. And in there, we're going to be using that for children. But we also are going to be looking at how to make the process a little more engaging, because we know that experiments with brain-computer interface, because you're not moving anything, you're just staring at a screen, sometimes it can be very tiring. It can be very disengaging, and children usually they just lose focus so fast. So what we want to do in this case, and this is where the POR main part of our research goes, is how can we engage them more? How can we make them feel that they are doing something that they want to do, they keep wanting to do, and come back again to the lab? So the 2 strategies we're thinking of using with children is implementing different interactions with the screen. So depending on what they click or what action they do, the screen's going to behave in a certain way. We're also looking at how to implement brain-computer interfaces with games, so that they can not only be doing the task, but also doing something in the game, like achieving some goal in the game. And depending on the age of the children, if they're like younger, let's say 10, 12 years, instead of like more towards the young adult age, we're also thinking of doing stories and involving the sessions in stories, telling them something that's going to get them involved in the sessions. So we're going to be using, 5 children, ages from 10 to 17. And we're going to be measuring accuracy, and we're going to be asking for, after each session, what we call the usability measures. So the usability measures are going to basically try to make us understand, how are they feeling using that system? Is it easy enough to be used? Is the system helping them to achieve the goals they're trying to do? Is the system letting them more fatigued or less fatigued? And how much is the usability overall of the system helping them do something that they weren't able to do before? Yes, and then after we have that, the type of system set up, we can use that not just for games, but we can also use it for spellers, help them with communication, use that system for electrical chairs, using cursors, robotic arms, so they can play in the real world, sorry. And yeah, so our research doesn't have yet like preliminary results, because we're still in the process of getting patients from the Glenrose, and let us do all the process for COVID, because when COVID hit, we had a lot of barriers, so to speak, that we are trying to figure out right now on how to go back to research. And yes, so our project, it's basically that part. I want to thank the Alberta Innovates for having supported this research. Also the Glen Rose Rehabilitation Hospital for allowing us to have participants and for allowing us to be part of their clinical process, and also for the SMART Network for having supported this research as well. And I'm glad to have questions.
Thanks so much, Matheus. That was a wonderful presentation. If you do have questions, please feel free to post them in the Zoom chat box, or if you're in Whova, post them in the Whova chat or the Whova question box. Christine, do we have any questions over in Whova?
No, we don't this time around.
Okay, I actually had a question for you, Matheus. You mentioned that you come from the world of engineering, and you've stepped into healthcare, where patient engagement, stakeholder engagement is a different kettle of fish. So I'm wondering what that experience has been like for you, and how that has maybe grown your perspective as a budding researcher.
Yeah, well, absolutely. That's something it's super new for me, because usually in engineering, that's not something we don't care about that very much. We just want to test the system and see if it works. But now talking to my supervisor, it's always learning new things. So like doing usability measures, questionnaires, forms, and thinking about how they're going to be doing the experiment, if they're going to be liking it or not, if they're engaged or not. All those things are super new for me. So it's been quite a great opportunity, and all the training that I received from the SPOR grant that opened my mind a lot as well. So it's been pretty interesting, and I think it's the best combination, using technology, but also whatever the participants can contribute to make the project work the best. So I think it's going to be interesting to see the final result.
That's great. Thank you for that thoughtful answer. And I'll follow that up with a question asking, tell me more about how and where in the points of your project patients, or perhaps in this case, their parents, were involved in the project.
Yeah, so they're going to be involved because most children, they are going to have cerebral palsy or other types of disabilities that sometimes make them harder to speak, harder to tell what they are feeling, how they're feeling. So parents are going to have a great help in that sense as well. And also the occupational therapists from the Glen Rose that already have like a relationship with the participants and the patients. They're going to have a great importance because of the feedback they're going to let us know. Like they're going to tell us if that is something they like, they don't like. We're also going to have some flexibility in our system to personalize it for each participant. So let's say there's a color, there's a character, or there is some kind of setup that they like better. All those things, we're going to try to get that from them using parents, occupational therapists, and that is how we're going to try to implement as best as we can their opinions and whatever they like. Hello?
That's great, Matheus. Thank you. I'm not sure where Kelly went.
Oh, I see.
Sorry, my mic was muted.
Oh, right, no problem.
I was going to say that as another follow-up question, in terms of broader impacts and broader reach of the outcomes of your research, how do you see, I guess, from a knowledge translation, dissemination perspective, what are your plans for that?
Great, so that's a good question. Well, first of all, we're doing all that research in what we call the ICANN Center in the Glen Rose Rehabilitation Hospital. So it's a program that not only has children, but also adults and other patients that are willing to test brain-computer interfaces. So the first benefit we're going to have from this research is that the system we develop is going to be allowed to be used in the ICANN Center. So patients from the Glen Rose are going to be the first benefited from it. The second thing our knowledge translation is going to be doing, we're going to be doing for knowledge translation, is that we are part of national program. It's a national team, so to speak. It's a network that's called the BCI CAN, so the Brain Computer Interface Canada Network, which includes the University of Calgary and the University of Toronto. And we all have like this network where we share results, we share experiments, we share experiences. Every month we do like a monthly meeting. And so all those things are going to be shared through that network that's going to be allowed to be tested in different sites. And all those results may be gathered in the future for like a paper or testing the same methods. So as far as knowledge translation goes, I think for the short plans, those are the ones.
Okay, perfect. Thank you so much, Matheus, and wonderful presentation. Very well done. I'll move on next to our next presenter, Danielle Fox, who is doing a PhD in health services research at the University of Calgary. And today, Danielle will be presenting on facilitating successful transitions to home dialysis therapies. Take it away.
Great. Hi, everyone. Can you see my screen okay and see me okay?
Yes, it looks perfect, Danielle.
Great. So thank you very much for taking the time out of your day to come and listen. And of course, thank you to SPOR for providing this opportunity to share my proposed work. Again, my name is Danielle Fox, and I'm a registered nurse and also a PhD student in the Department of Community Health Sciences at the University of Calgary under the supervision of Dr. Rob Quinn and Dr. Dave Campbell. And so in Canada, the number of people with kidney disease is increasing, and this is ultimately leading to more people needing to start dialysis, which is a treatment that does the job of the kidney by cleaning the waste products from the blood and removing extra water in the body. And the most common type of dialysis is in-center dialysis, and this is where people come into a facility for normally 4 hours at a time and 3 days a week to have their dialysis treatment performed for them by a healthcare provider. And in-center dialysis is great, but it's also really expensive to provide. And so because of this, among many other reasons, kidney programs across Canada are really promoting the use of home dialysis. However, home dialysis requires the patient or the support person to perform the dialysis themselves. And because of this, it really requires a lot of support, especially as people are quite sick with their kidney disease already. And this support was really especially important during the transition onto home dialysis, where there was not only a big learning curve, but also other stressors in patients' and families' lives that made this a particularly challenging time for a lot of people. And so for my PhD research, we want to co-design a patient and family-driven intervention that really individualizes support and care processes for people transitioning onto home dialysis with an ultimate aim of really just improving this experience. And so we plan to carry out this work in 3 phases, but first we will be forming a steering committee to guide this work. And this committee will be made up of patient and family partners, national home dialysis experts, home dialysis clinicians, and administrators. And the first phase of this work, we're going to perform a scoping review to really provide a summary of the available literature, which will be synthesized in 2 parts. And so first, we're going to be taking the qualitative literature that is focused on the patient experience during this time, and we're going to perform a meta-ethnography. And so essentially, we're going to synthesize all of the qualitative data and interpret it together to give us a better sense of what this transition experience is like for people. And then next, we're going to take all of the studies that focus on implementing an intervention or evaluating an intervention that aims to improve this transition, and really to synthesize them to try and identify interventions that have worked well, why they worked well, and in what circumstances or context they worked best in. And so then the second phase of this research, we're going to be conducting an ethnography, which is a qualitative study that really is going to aim to document and explore the care experiences and support needs, but just in a lot of greater depth. And so 10 to 15 patients who choose home dialysis in Calgary are going to be recruited using a purposive sampling technique and followed from when a decision is made to start home dialysis to 3 months on therapy. And participant observation and in-depth conversational interviews are going to occur at key moments during their transition, as well as collecting and analyzing documentary sources, so such as training instructions or other things provided to the patient. And our data is going to be synthesized, analyzed, and interpreted to really get a sense of what people go through throughout the transition, what their support needs are at different time points, and ultimately to determine how care might be delivered differently to better support and meet their individual needs. And then in the third phase, we're going to be taking a broader lens to identify priorities during this time across Canada. And so key home dialysis stakeholders are going to be mapped, and we're going to be administering a Delphi survey to identify care priorities of different stakeholders. And this will include patients, their support people, clinicians, and administrators. And then the first round of the Delphi survey, we're going to be using open-ended questions to really identify priorities in a broader sense during this time point. And then the list of priorities is going to be developed from the data that we receive, as well as from phases 1 and 2 of this work. And then additional rounds of the Delphi survey will then occur in a more structured format where participants will score priorities in order of importance until a list of top 10 priorities in care during this time are developed with a 70% consensus. And then lastly, we will be holding a workshop with various stakeholders, which will bring the information from all of these phases together. And then using a nominal group technique, we're going to aim to generate an idea essentially for an intervention that would meet these needs and that we could develop and implement in future work. And so with that, I'd like to open the floor to any questions and of course, welcome any feedback you might have. But of course, first wanted to say a big thank you to my supervisors, my committee, and of course, a huge thanks to the SPOR platform for supporting this work and providing patient-oriented research training. It was extremely helpful, and as well to the ICDC, who also played a big part in supporting this work. Thank you.
Okay, thanks so much, Danielle. Wonderful presentation. And I'll throw it over to Christine and ask if there are any questions that have come in on her end.
Yes, there's just the one, which is in the chat from Zoom, and it says, do you expect priorities might include mental health needs?
Yeah, so that's a great question. And so actually where this idea came from a project was from my master's work, where I did a mixed method study aiming to identify support needs for people on peritoneal dialysis across the board. And so we focused on the 4 types of social support. So instrumental support, appraisal support, informational support, and of course, emotional support. And emotional support really came out as a big priority, and in a lot of circumstances was an unmet need. And so I anticipate that mental health needs, and particularly around emotional support and support with coping and different care priorities around that realm, will come out as very important for sure, and definitely something that we are considering.
That's great. Thanks for that thoughtful answer. Christine, are there any other questions over there in Whova?
No, there isn't.
No? Okay, I'll ask a follow-up question that I have. How are you working around COVID-19 to have the best project possible?
Yeah, so that's a great question. So as you can tell by my project, it's very in person. And so I think, first of all, with COVID, the need for this project is actually more, just because, you know, a lot of people within the COVID realm, it's really important that we keep our patients safe and at home. And so a lot of people are opting to choose home dialysis instead of in-center types of dialysis. And then because of that, it's also more important that we're able to meet the needs of perhaps a different demographic of patients that are wanting home dialysis during this time. And so first of all, the need is great. And then second of all, in terms of the project itself, we might just have to do some workarounds. Right now, we're just looking at finalizing the proposal and doing some literature review, so that won't be impacted. But particularly for the second part of this study, we might flip the phases. And then if COVID is still kind of impacting in-person research at that time, then we're going to look into alternate sources of performing the ethnography, either by doing an online type of ethnography method, and as well as having more perhaps patient-led data collection methods and using online interaction forums from my perspective.
That's a great response, and definitely being very flexible in terms of shifting your project to deal with the outcomes of that we're all experiencing relating to COVID. I'm wondering, so you did a really great job situating your research in the greater body of literature. I'm wondering, what do you foresee as being the impacts of your research, and what do you foresee are some potential future directions that other researchers could take after your project is over?
Yeah, so I think for sure the impact of our research, I think right now, especially with home dialysis, you know, I think a lot of people you know, they learn differently, they have these individualized needs, and yet I think the way that oftentimes care is provided in a structured way in our healthcare system, and ultimately that's just, you know, there's so many reasons for that that are very valid. And I think one of the things that this research is going to bring forward is potentially provide solutions to really bringing more flexibility into the way that we provide care as a healthcare system, and especially from an outpatient perspective that really can meet individualized needs in a different way and change care pathways and care trajectories differently. And I think that that is going to have a lot of impact to the patients, but also to the providers, because I think, you know, although, you know, patients and families certainly have these needs, oftentimes as providers, we have needs as well in the way that we can optimize care for our patients. And so I think ultimately by developing an intervention that is led by a variety of stakeholders, I think that hopefully we can change care within a home dialysis perspective that is not only impactful to the patient, but also positively impacts the way that care is provided from the part of the clinic. And so that, and then sorry, what was the second part of that question?
I'm trying to remember now what I asked. Yeah, no, I think that covered it. I was asking about the broader implications of your research, and I guess what other, what could later researchers building on your research? Yeah.
For sure. So I think with this, like, and definitely with my master's work for sure, like when you start talking about patient experience and things that impact patient experience and things that impact support needs of patients and families, I think it's so vast. And, you know, once some of these priorities and care and needs start to be identified, there will be a lot of opportunity for future work to target individualized needs and care priorities outside of our immediate next steps.
Oh, very good. Thanks so much for that response. And thank you for a wonderful presentation, Danielle. I'll move on next to our last presenter, Trina Thorne. Trina is doing a PhD in the faculty, a PhD at the University of Alberta, and her project is on care aids experiences caring for residents with a history of psychological trauma. So Trina, I'll turn it over to you. Are you able to share your screen? Oh, there we go. Perfect.
Hi, everyone. Can you hear me okay?
Yep, you sound great, and we can see your poster.
I was so ahead of the game sharing or expanding the poster, and I locked myself out of share screen. Anyway, thank you everyone for hanging in and joining me for my presentation today. I too would like to thank the Alberta SPOR Support Network for giving us that excellent training course, and of course funding our research and my ability to cut back on my clinical hours, which has been crucial with the COVID outbreak. This project is situated within Dr. Carol Estabrook's Translating Research and Elder Care Applied Research Program at the University of Alberta and the Faculty of Nursing. Dr. Estabrook has an emerging trauma program, and she has assembled a core group of experts in trauma, dementia, neurology, and dementia quality of life that I will work under. I had originally become broadly interested in knowing more about responsive behaviors while working as a nurse practitioner in long-term care. And just so you'll know, responsive behaviors are also referred to as behavioral and psychological symptoms of dementia or neuropsychiatric symptoms, and sometimes BPSDs. So I joined Dr. Estabrook's lab as a research assistant in 2019, shortly before starting the program. And it was then that the topic was reduced to focus on responsive behaviors that may be related fully or partially to past psychological trauma. And COVID has significantly impacted this project. I was originally looking at a focused ethnography, and we were really focusing on the perspective of residents. And as TREC has the Voices Citizen Advisory Group, they were going to assist us with some of that. But the crisis that has emerged in long-term care has kind of shifted my focus slightly to either a dual focus on care aid and resident outcomes, but definitely includes the care aid perspective more. And so the purpose of this study is to understand the experience of providing care for long-term care residents with dementia and psychological trauma. And so it's kind of an initial step in this larger program. So trauma itself results from an event or series of events that are experienced, nearly experienced, or witnessed. And some examples could be natural disasters, sexual violence, serious physical trauma. And over 75% of Canadian adults report exposure to at least one potentially traumatic experience. And of those individuals, usually about a quarter will go on to have some form of a traumatic stress disorder or traumatic stress injury afterwards. And the lifetime prevalence of PTSD in Canada is 9.2%, which is interestingly the highest of all the OECD countries. For older adults, research suggests that the prevalence in the community is 3 to 6%, but in long-term care estimates are as high as 22%. And there's no real strong studies to explain why, but we speculate a lot of the transition to long-term care itself can be traumatic, and there's a lot of loss experienced in that time frame as well. It could be the loss of a partner, a caregiver, your loss of community, your own physical function, hospitalization. So it's speculative, but there's lots of reasons one could imagine that the rates could be higher in long-term care. So trauma can have persistent adverse effects on mental, physical, social, and spiritual well-being. And it took a long time for us to get to that place where everyone kind of acknowledges that. But I think people are now recognizing the impact it has over the lifespan. However, research is limited on those manifestations, and particularly into old age. Care aides are often referred to also as personal support workers, and they need urgent support and evidence-informed person-centered strategies to manage the impact of trauma in long-term care residents with dementia. In the US, a trauma-informed approach was implemented in November in long-term care homes and is now an essential regulated component of person-centered care. In Canada, however, strategies for managing trauma in long-term care homes have not been developed or implemented. The literature on residents with psychological trauma living in long-term care is scarce. I was only able to locate one small Swedish study that examined the experience of care aides specifically with Holocaust survivors, and one larger Australian study that explored the experience of providing care for Holocaust survivors from a variety of caregiving experiences or perspectives. What we find is over 90% of the direct care for long-term care residents is provided by care aides or personal support workers, and they are the most familiar with the residents. They provide all intimate care and are therefore most likely to manage behavioral responses. In most cases, care aides do not receive adequate training on responsive behaviors and no training on the potential impact of psychological trauma. Supporting care aides as they provide complex dementia care is an essential component of a long-term care environment that supports quality of care, resident quality of life, and staff quality of work life. My research objectives are first to describe and understand the perspectives and experiences of care aides working with residents who have both dementia and a documented or perceived history of psychological trauma. Second, to identify and further characterize potential factors that influence the decisions of care aides in managing responsive behaviors that they suspect may be due in part or in whole to residents' trauma. And third, to identify potential strategies that care aides perceive as useful to their care practice related to specific traumas or responsive behaviors. And responsive behaviors, which are common in long-term care settings, may be triggered by non-dementia sources of stress. Residents with dementia, we know, react strongly to stress, and residents with trauma can have extreme behavioral responses to stimuli that remind them of a stressful experience. It is also thought that dementia can inhibit the ability to suppress past traumatic memories, and there is emerging evidence indicating that some of what was once thought to be symptoms of dementia may in fact be manifestations of trauma. When responsive behaviors are directed towards care aides, for example, being yelled at, scratched, or hit, they decrease quality of work life and lower quality of care. Our needs assessment, we completed a needs assessment last summer. I shuffled the order of my speech here. And Dr. Estabrook and I developed and field tested 4 questions about trauma for care aides that was included in the larger TREC survey that thankfully was finished in the field just before COVID hit, within weeks. And of the 3,700 care aides surveyed, we got 2,000 responses on that model. And this needs assessment found that care aides are able to recognize signs of trauma and can link these signs to specific types of trauma. For instance, sexual assault versus physical assault versus neglect. It also found that they frequently encounter residents with traumatic histories and struggle to find strategies to assist them. This study will expand on that early work. And this qualitative study was actually designed using Thorne's interpretive description approach. I was originally going to do a focused ethnography, but not now being able to do an observation in the long-term care home, most likely due to the COVID-19 pandemic. This approach kind of presented itself. And actually, as I learned more about it, I think it might have been the preferred approach all along. Or a better fit. I will purposefully recruit a diverse sample of approximately 48 care aides from 4 possible combinations of ownership model. So that would include for-profit or not-for-profit, and care unit type. And that would be a dementia secure unit versus a regular long-term care unit or a specialty type. We have some care homes that are veteran homes and other specialty types, mental health, serious mental illness. As these factors are thought to influence not only staff work-life outcomes, but resident aggression. Using a concurrent analysis, I will compare patterns across these 4 groups, noting consistencies and theorizing relationships in order to construct an aggregate interpretive account of care aides' experiences that can be used to produce sound clinical knowledge to benefit both residents and care aides. This proposed study is the first on psychological trauma in Canadian long-term care settings to our knowledge, and it will contribute to Dr. Estabrook's emerging trauma program. And for outcomes or impact, it's designed to build a knowledge base for developing strategies to manage responsive behaviors in general, and more specifically, those related to trauma in long-term care residents with dementia. And we have been fortunate to involve some of the senior decision makers in Alberta Health Services and Alberta Health along the way. And in terms of engagement, it has been, it's evolved over time, but I had originally been speaking informally with the Voices group, which I think we will continue to involve for sure, but also I'm hoping to develop an advisory panel of care aides, and the details of that have not been worked out yet, but that is something that there's another study in Trek that's looking to do the same thing, and so maybe we can share a group or make it work somehow. Dr. Estabrook's developed the Royal Society, or she was the chair on the Royal Society of Canada long-term care committee for the impact of COVID-19. And I helped develop the appendix with all the reports for the Restoring Trust paper that produced. And when I looked through the reports over the past 10 years, it was 48 reports, and 31% of them included as a priority either supporting with resources and financial, but training for responsive behaviors in long-term care. So from my own clinical experience and from we know in the literature in terms of the impact these behaviors have on resident, family, and staff quality of life, I'm hoping it's meaningful, but I still have more work to do to kind of support that. So again, thanks everyone, and thank you for all your generous support and for hanging in here.
Thank you so much for that very insightful presentation, Trina. I'm going to ask Christine if we have received any questions over in Whova.
No, but there is one that just showed up in Zoom.
Oh, yes.
How has COVID-19 impact trauma, triggers, or distress? And is there a way to capture that for each population, both residents and staff?
So I don't think we totally know the answer to that scientifically, but in my experience, still working in long-term care as we speak, people are tired. I think we've been doing surveys. The Health Quality Council of Alberta has been surveying us, and I think will be emerging data. And our Trek team, we submitted a grant with CIHR because we had just finished the trauma survey, and it looks at staff burnout. It looks at SF8, like mental and health and physical health. It was very timely because then we can do a pre-post or pre-during. And so I think there will be a lot of evidence emerging, and I suspect it would be what we would all anticipate in terms of mental health decline. One thing about care aides, though, is although they have higher rates of burnout, they also have higher rates of self-efficacy and engagement in their work. So, there's similarities across disciplines, but I think we should anticipate that different disciplines will respond differently. And also care aides have been particularly targeted. And there's been a lot of stigma in terms of being blamed for bringing COVID-19 into the long-term care homes. And I think a lot is misdirected instead of looking at why Canada has almost double the rate of deaths in long-term care compared to the other OECD countries. I think the average across the 13 countries was 44%, and Canada's sitting at 80% of the COVID deaths are in our long-term care. So there's system issues there.
There was another question that came through in Zoom, and it says, your study seems to focus on strategies for HCAs when dealing with trauma and responsive behaviors. Do you expect you might also have findings about how those affect HCWs and how they might cope with this stress?
So healthcare, HCW would be a healthcare worker?
I believe so, yes, healthcare worker.
No, they might, that might be an HCA. So HCAs, healthcare aides, unless they're thinking of the LPNs or the RNs. And so, to be honest, I think the strategies that emerge would be helpful for any discipline, right? I think the care aides are the best position to provide us with that information, and we very well may down the road interview RNs and LPNs, but they do know the residents best and do spend the vast majority of direct care time is by a care aide. And so LPNs will do wound care if they do the medication rounds, and they do provide some other basic care, and that'll shift depending on the model a home has. But generally speaking, they're the front line. But I think probably not only could this translate to other disciplines, it could probably translate to other settings. Because if we do find strategies that appear and emerge over and over and over again, and even in the home care setting, maybe they could be applied or tested there.
Thanks very much, Trina. It looks like we have one more question in the Zoom chat. Nancy is interested in first responders, and how does this connect to your work?
Not generally. I think the first responders stand out to me in terms of their high rates of PTSD and work-related PTSD. I think you'll find, I don't know, but we suspect nurses' rates are lower. But they also are not studied, so maybe they're not lower, right? ICU nurses have been studied a fair bit, but I think, you know, I think it's, in our needs assessment, we did come across police officers or EMS in the examples that the care aides provided. So I think it's very legitimate and it's important. And I think, you know, as our population ages, these positions or careers weren't around. So primarily the majority are either domestic violence that came up in examples, veterans, a lot of veterans based on the cohort, right? So I think that will be something we'll have to be aware of, but it doesn't totally fit into this study.
Thanks very much for that, Trina. And I guess one final question. You've talked a little bit about a general knowledge translation plan you have for your research. I'm wondering if you can comment on any specific barriers and facilitators that you might foresee with respect to uptake of the findings of your research by knowledge end users.
Yes, so thankfully, Dr. Estabrooks is a research chair, tier 1 of knowledge translation. And so she, in all her research, integrates the IKT. And so we have been engaging the decision makers, like I said, with Alberta Health Services, and like Jim Silvius with the Strategic Clinical Network. And zone directors have committed to working with us to develop resources when it's done, when the study's done and the findings are in, and disseminate them. So we've got that, as well as we always develop tailored feedback reports. So all participants will get the findings, which will help locally. But TREC has a network of 94 homes, and so we also distribute research findings to the entire network. And those are in the 3 Western provinces, but also has investigators across the country. Maybe in all provinces, maybe missing 1 or 2, but so we'll spread that information that way as well. And then I myself work for Alberta Health Services in long-term care Edmonton zone. So I think there's lots of different avenues, grassroots as well as the higher level, that we've got access to. And then barriers right now, I think, are information overload. I'm hoping that by the time the study's done and I have interpreted and am able to share reports, I'm hoping that the dust has settled with COVID-19, but I think it would be very hard to disseminate evidence and have people actually register it and try to implement it at this point.
All right, well, thank you very much, Trina, for a wonderful presentation. Very well done. We have a few minutes left, so just before we close the session today, I'll ask if you have any other questions for any of the presenters at this time. Please feel free to type your questions in the chat box in Zoom or in Whova. Okay, well, I guess if there's no more questions, I'll just say thank you to everyone, to our Studentship Awardee presenters today, and all of you who attended today. Please do continue to post your questions and comments for these presentations in Whova, and the recording of the session will be available to watch in Whova within about 24 hours from now. I'd also like to announce that the Twitter contest for favorite poster and video abstract is now open. Please be sure to vote for your favorite, and the winners will be announced after our closing plenary session on November 20th. Tomorrow, please be sure to join us for the second session on digital health and virtual research with presenters from the Alberta Clinical Research Consortium. That session starts at 12 p.m. tomorrow here in Whova. And on Friday at noon, please join us in Whova for our second virtual networking meetup. This is your opportunity to come together for a recap of the week's topics and to share with each other your takeaways and perspectives on what you learned this week for further discussion. And those of you who attend on Friday will be entered into a book draw. So I hope to see you there. Thank you everyone again, and have a great afternoon.